Okay, let's talk about older adult psychiatry. The most common psychiatric disorders in older adults are dementia and delirium. This chapter considers other psychiatric disorders in older adults. Aging is associated with an increased prevalence of both mental and physical health problems. Older adults may also face new social challenges such as coming to terms with retirement, income reduction, living alone or being separated from family, death of spouse, siblings, and peers, and coping with deteriorating physical health and mobility. Patients used to arbitrarily come under the care of older adult psychiatrists at the age of 65 years. However, concerns were raised that an automatic transfer to older adult services at a given age resulted in age-based discrimination. Instead, as needs-based approach is now being taken in the majority of areas, whereby patients with problems that older adult services are expert in are transferred, with everyone else remaining under the care of general adult services, whatever their age. Okay. There also has the advantage of maintaining continuity of care. Examples of patients that older adult services are best placed to manage are people with dementia of any age, people with a mental disorder and significant physical problems, or frailty which cause or complicate the management of their mental illness, like delirium, or someone with both schizophrenia and chronic obstructive pulmonary disease required nursing home care, or people with mental health problems closely related to the aging process, like a grief reaction or depression triggered by social isolation. Regardless of which services care for them, the number of people aged over 65 years is set to increase substantially over coming decades. Currently, 1 in 5 of the UK population is over 65 years of age, but by 2040, 1 in 4 people are projected to be aged over 65 years. The number of very old, aged over 85 years, is also continuing to increase. Okay. Mental illness in older adults. Epidemiology. The prevalence of all mental illness tends to increase with age and tends to be higher in residential homes. Here we have a figure that summarizes the prevalence of the individual psychiatric disorders in older adults. So, here we are talking about the prevalence of mental illness in people over the age of 65. Depression is about 10 to 15%, anxiety disorders 3 to 15%, dementia is 7% and 20% in people over 80, schizophrenia in 1%, bipolar affective disorder in 1%. Let's start with depression. Depression in older adults presents similarly to that in younger people, but a slightly different symptom set needs to be focused on. Symptoms such as fatigue, insomnia, and anorexia are more likely to arise in older adults for reasons other than depression, and so are less specific in supporting the diagnosis. Similarly, poor concentration and memory are very common in older adult depression, but could also reflect a cognitive disorder. Instead, negative cognitions such as guilt, hopelessness, and suicidality are given more diagnostic weight. There are also certain features of depression that are more common in older adults, like severe psychomotor agitation or retardation, cognitive impairment, sometimes called depressive pseudo-dementia, poor concentration, generalized anxiety, excessive concerns about physical health, hypochondriasis. When psychotic, older adults are particularly likely to have hypochondriacal delusions, delusions of poverty, and nihilistic delusions. Okay. Depression is often underdiagnosed in older adults, so high index of suspicion is needed. Older adults are also less likely to be referred to mental health services regarding depression. This may reflect a perception that low mood is part of normal aging. It is not. Effective management of depression is important, not least because older adults are at high risk for completed suicide, even though the prevalence of self-harm in this group is lower than younger adults. Okay. Red flag. Always think about depression in older adult presenting with abnormal illness behavior. Hypochondriasis is a common presenting symptom. Another red flag. Self-harm in an older adult should be considered to be with suicidal intent until proven otherwise. The principles of treatment are the same for younger adults, taking a stepwise approach guided by severity of illness. In addition, it's particularly important to check for physical problems or medication that can cause low mood, as the likelihood of these higher in older adults. Mild depression and subthreshold symptoms may befriending assistance in assessing community support such as lunch clubs, structured exercise programs. Okay. Psychological therapies for depression, mainly cognitive behavioral therapy, are just as effective in older adults as in younger adults and are recommended in those with moderate to severe depression. Psychological therapies are particularly useful for patients whose comorbidities place them at high risk of side effects from medication. The National Institute of Health and Care Excellence, NICE, also recommends antidepressant medication for those with moderate to severe depression. So we have mild depression and subthreshold symptoms, psychological interventions alone. Psychological therapies for depression for moderate to severe. Also, we have antidepressant medication for moderate to severe also. Although medication should be introduced cautiously, as older adults have an increased risk for developing adverse side effects and generally need lower doses. Selective serotonin reuptake inhibitors are first line, of course. Tricyclic antidepressants should be avoided if possible, as the postural hypotension and cognitive impairment are very common side effects in older adults. Response to antidepressants is often slower in older adults, with benefits taking 6 to 8 weeks to emerge. Lithium augmentation may be used in treatment-resistant cases, although the dose is generally lower than that used in younger adults. Okay. Hints and tips. Some SSRIs side effects are more likely to occur in older adults than younger adults, like hyponatremia, so consider monitoring sodium, gastrointestinal bleeding, so consider proton pump inhibitors, and drug interactions, least likely with citalopram and sertraline, of course. Electroconvulsive therapy is a very effective treatment for severe depression in older adults and should be considered for severe symptoms of psychosis, suicidality, and life-threatening food and fluid refusal. Dementia is not a contraindication. Poor prognostic factors include comorbid physical illness, severity of illness, and poor concordance with antidepressant medication. Okay, these are the poor prognostic factors. Comorbid physical illness, severity of illness. Okay, let's get back to this. Severity of illness and poor concordance with antidepressant medication. The median duration of an episode is 18 months, longer than in younger adults. Having depression reduces life expectancy in older adults by, on average, 3 years, even when physical illness is taken into account. It also doubles the person's risk of developing dementia. Okay. Hints and tips. Cotard syndrome describes the presence of nihilistic and hypochondriacal delusions as part of a depressive psychosis and is typically seen in older adults. Another hints and tips. Common triad in older adults is depressive symptoms, cognitive impairment, and functional impairment. It is often difficult to tease out whether someone is experiencing depression manifesting with cognitive impairment or an early dementia leading to comorbid depression. Ideally, depression is treated first, then cognitive reassessed once mood is euthymic. So this is about depressive disorder in older adults. Okay, about anxiety disorders. Studies that have assessed prevalence of anxiety disorders in older adults alongside younger adults have found that anxiety disorders reduce with age. Generalized anxiety disorder is the commonest specific anxiety disorder in those aged over 65 years, affecting 2 to 7%. Specific phobias affect around 3%, and social phobia, obsessive compulsive disorder, and panic disorder are all uncommon, each occurring in less than 1%. It is rare for anxiety disorders to arise for the first time in older adults. Importantly, anxiety, particularly health-related, is a common presenting symptom of depression in older adults. So, anyone presenting for the first time with anxiety in later life should be carefully assessed for depression. Treatment of anxiety disorders in older adults is broadly similar to that in younger adults, with evidence supporting benefits from both medication and psychological therapies. Although psychological therapies appear to be not as beneficial as in younger adults. Benzodiazepines should be avoided where at all possible because of the risks of cognitive impairment and falls in older adults. Okay. So, mania. Unlike depression, the incidence of bipolar affective disorder does not increase with age, although late-onset cases seem to be less influenced by genetic factors. Fewer of these patients have positive family histories for mood disorders. In a fifth of cases, mania is precipitated by an acute medical condition like stroke or myocardial infarction, making it particularly important to screen for physical or medication causes. Hyperactive delirium is an important differential. The presentation and treatment are similar to those for younger children or younger adults. Okay. Late onset schizophrenia or late paraphrenia. Older adult psychiatrists in the UK use the term late onset schizophrenia or late paraphrenia to denote a group of patients who develop their first psychotic symptoms late in life, usually over the age of 60 years. Late onset schizophrenia is characterized predominantly by delusional thinking, usually of a persecutory or grandiose nature. These delusions tend not to be as bizarre as they sometimes are in earlier onset schizophrenia. Rather than believing that secret agents are monitoring them by satellites, a patient with paraphrenia may assert that the neighbors have been poisoning their water supply or so. Hallucinations may occur, but disorganized thinking, inappropriate affect, and catatonic features are rarer than in younger adults. The key differentials are dementia, delirium, or medication-induced psychotic symptoms. The etiology of late-onset schizophrenia seems different to early-onset schizophrenia in that affected patients are less likely to have a family history of schizophrenia. In addition, late-onset schizophrenia is far more common in women than in men, unlike early-onset schizophrenia, which is slightly more likely to arise in men. Sensory deprivation, particularly hearing loss, and social isolation are also implicated in its etiology. Okay. The treatment is with antipsychotics, but some work is needed in building up a therapeutic relationship, as these patients are often difficult to engage and poor concordance is associated with poor treatment response. Note that although late-onset schizophrenia does seem to be a distinct entity, it is not a term used by the ICD-10 or the DSM-5 here. These patients would be classified as having schizophrenia or delusional disorder. Hints and tips. Diogenes syndrome. Okay, Diogenes syndrome is the term used to describe a self-isolated person who lives in a state of significant self-neglect, which may include hoarding and lead to squalid living conditions. This is purely a descriptive term and may occur in individuals who misuse alcohol or have frontal lobe dysfunction, personality disorder, and chronic psychotic illness. It may also occur at younger age. Okay. Assessment considerations in older adults. Home assessments are a very important part of older adult psychiatry. Patients can be assessed in their normal environment and collateral information can be obtained from family members. It is important to ascertain whether the patient can be managed at home. That means if there is risk of harm to self or others and ability to carry out activities of daily living, drive, manage financial affairs and so on, or whether additional community support or hospitalization is needed. Collateral information from the patient's general practitioner, family, and carers is an important part of history taking. Ensure that the patient has any aid they require to optimize their communication, like glasses, hearing aids, or dentures. Mental state examination follows the same format as for all adults, although extra consideration should be given to the assessment of cognitive functioning, and it is advisable to always do a standardized test. Although physical assessment is very important, this may be best done by the patient's general practitioner. Do not forget to consider hearing and vision as well as tremors and involuntary movements. Routine investigations in newly diagnosed or hospitalized older adults include full blood count, urea and electrolytes, liver function test, thyroid function test, calcium, glucose, urine analysis with midstream urine microscopy and culture if indicated, chest X-ray, electrocardiogram, and consideration of serum magnesium, phosphate, vitamin B12 and folate, and a computed tomography or magnetic resonance imaging of the head may be required. Remember that the chances of a physical illness causing or aggravating mental disorder are significant in older adults. Treatment considerations in older adults. Physiological changes with aging. There are a number of physiological changes that occur with aging, which may affect the way the body handles certain drugs. Here you have a table that describes the most important changes and their effects. We have reduction in renal clearance, glomerular filtration rate, and tubular function. That would affect drugs excreted by filtration like lithium. That's why we need lower doses. And drug concentrations may rise rapidly with dehydration and heart failure, etc. Another physiological change is decreased lean body mass and total body water and increased body fat. That would affect the volume of distribution, because volume of distribution increases for lipid-soluble drugs, most psychotropic drugs are, and reduces for water-soluble drugs like lithium. Half of lipid-soluble drugs prolonged. Another change is decreased plasma albumin. So that would reduce drug binding, resulting in increased physiologically active unbound fraction. Another change is reduced hepatic metabolism and first-pass metabolism that may increase the bioavailability and elimination of some drugs. Another change is increased sensitivity to central nervous system drugs. So sedating agents or sedating drugs may result in drowsiness, confusion, falls, and delirium. Tricyclics are more likely to be associated with anticholinergic and postural hypotension effects. Antipsychotics are more likely to be associated with Parkinsonism and increased risk for cerebrovascular accident. Another change is decreased total body mass. So lower doses of drugs needed. Think in terms of milligram per kilogram as opposed to standard dose for all. So, the net result of these changes is that the tissue concentration of a drug may be increased by over 50%, especially in malnourished, dehydrated, and debilitated patients. Therefore, the adage start low and go slow applies especially for the use of psychotropic drugs in the older adult. Polypharmacy. In 2012 to 2013, around 80% of those aged 65 and over in the UK were taking at least one prescribed medication, with around 2/3 taking 3 or more, and a quarter taking 6 or more. Polypharmacy increases the risk for adverse reactions, drug interactions, and poor concordance. Therefore, prescribing psychotropic drugs for common self-terminating symptoms such as insomnia and headaches should be avoided whenever possible. When psychotropic drugs are recommended, follow-up arrangements should include a timely assessment if response and discontinuation if ineffective treatment. Again, so follow-up arrangement should include a timely assessment of response and discontinuation if any ineffective treatments. Medication should not be a substitute for adequate social care, the lack of which often underlies many non-specific symptoms. About concordance. Concordance is often a problem in older adults, especially with those who are visually impaired, cognitively impaired, taking numerous drugs, and live alone. This may be improved by simplifying medication regimens, taking time to explain dosing schedules, using large font prescription labels, or concordance aid such as dosage boxes. Organizing supervision of medication by a relative, friend, or support worker may be necessary. What about psychosocial interventions? Psychological treatments, such as a cognitive behavioral therapy, can be used with success in older adults, as with younger adults. Reality orientation and reminiscence therapies have been used to reduce disorientation and stimulate remote memories in patients with dementia. Practical psychosocial interventions, such as memory aids like notes, books, and calendars, and assistance in mobility and daily activities by a support worker should not be underestimated. Occupational therapy assessment for activities of daily living, which assess skills such as washing, dressing, eating, shopping, give carers an indication of patients' strengths and weaknesses, and enable a care package to be tailored that caters specifically for those. Okay, here we have this chapter summary. Mental illness in older adults is overall similar in presentation and management to younger adults. Depressive episodes in older adults often have prominent features of cognitive impairment, agitation, and health-related anxiety. Self-harm in an older adult should be considered to be with suicidal intent until proven otherwise. New onset mood, anxiety, and psychotic illnesses are rare, but do occur. Be cautious with psychotropic medication use in older adults. psychological interventions are effective in older adults. So that's it. هذا والله تعالى أعلم. وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.